wondering, our entry-level physical therapy program is actually a joint program with San Francisco State. So that's why you see the UCSF and San Francisco State logos here, is that we are a joint program. So without further ado, let's get going. And first, I also wanted to thank Dr. Call for the really good intro that helped explain a lot about like what each profession does. So I won't have to go into that in too much detail, but for those who arrived late, I'll touch on it a bit. So we're going to talk about what physical therapy is. I'm pausing for a second because Stevie also did a great example of speaking slowly and clearly, and I do not. So I'm trying really hard to keep the energy up and the speed down. Okay. And so next we're going to talk about how physical therapy can help with MSA, and talk about specific strategies to stay safe and stay active. So like Stevie gave you a lot of examples of how to use thickening, different types of thickening agents, different types of eating strategies. I'm going to give you some concrete examples of what to do and what to try until you can get to CPT. And then we're also going to talk about the long-term plan for maintaining that relationship with your physical therapist and sort of not falling through the cracks. And so that's what I mean by the dental model. But we'll get there all in 30 minutes. And if you're wondering why I'm wearing such sparkly attire, I'm part of the Peninsula Musical Arts Association, and we have our spring choir spring concert this afternoon. So I'm going straight there to sing everything from Route 66 to part of Toreador. So yeah, if you're interested in some concert choir, look up PMAA. Shameless plug, sorry. All right, so what's physical therapy? So we are licensed healthcare professionals that specialize in movement. So all of the systems that incorporate movement. It's actually been a doctorate entry-level degree since 2016. Most states have direct access to physical therapy. So legally, you can actually just walk in and see a PT. Getting it paid for requires a referral from a physician. So that's kind of the insult to injury still that we're fighting for, is that usually, and especially Medicare, won't pay for it unless you get a referral from a physician. And we'll talk more about Medicare reimbursement later. But physical therapists work with all kinds of movement, from sports to infants and everything in between. Okay, so we talked, Dr. Call talked about what each profession does. So I want to give you an example. Say you want to go out for a meal. So physical therapy will actually help you get from point A to point B, help you sit up and get out of bed, stand up, have the balance to walk, locomote, propel, whatever mode of mobility it takes, and balance and strength and endurance to get from point A to point B. The occupational therapist will make sure you're presentable. So make sure you can get your clothes on, that you've bathed, that you can use the utensils at the restaurant. And then as you just learned, the speech language pathologist will make sure you can actually eat safely and carry on a conversation clearly. So we all work together, and there is a bit of overlap, right? Because physical therapists will help you stand, and OT wants to make sure you can stand up from the toilet, or you need to lift up your foot to get in and out of the bathtub. Well, the OT and the PT can also help figure out how to organize your environment to do that. So there are some shared skills. What strategies do we use? So how do we do these things? Or what are we thinking about when we're working with anyone? Not necessarily just MSA, but all neurodegenerative illnesses and pretty much any movement problem. First, we think prevent. We think for the future, what are we trying to avoid? And the big one, you can probably guess, is falling. The biggest thing that can contribute to a negative outcome or a worsening is having a fall for anyone, period. Compensate. You're like, why didn't you put a picture of a person on the toilet? I was going to put using a walker because that's an obvious compensation, right? Doing something differently, either using a device or using a different strategy. And I put the picture of the toilet here is for the grab bars, right? Just having a grab bar there is a compensatory strategy, just doing something slightly different in order to get the job done. You know, a raised toilet seat would be another strategy. You just saw a bunch of augmented communication tools. The communication board, that's a different strategy. So it can be anything from doing something differently to using a different technology. And then typically the third bucket, for someone with like an ACL tear, we call it recover. You know, can you get back to normal? But I didn't want to put that here because if we're dealing with a neurodegenerative illness, from MSA to Parkinson's to MS to any of them, that definition degenerative, it means that there is this decline. And that's why we're looking at the white sort of downward slope here. But we're hoping to do with movement, with mobility, is change that slope. Because we can't change those, the alpha-synuclein proteins in the brain. We can't, as far as we know. We know that exercise makes a brain-derived neurotrophic factor, but we don't know on the metabolic level what exercise does. But we do know that that body that has a brain also has a heart, has a skeleton, has muscles, has joints, has lungs, has all those systems that help support your movement. And those are levers we can pull. Dr. Call was saying that OTs looking at your strengths. What resources do you have? We all have to look at those resources, right? Your heart beats, you can move, you can do these, whatever you have, start there and then start moving. And so especially the heart, because if your brain's not getting oxygen, if your lungs not getting oxygen, then that's a recipe for decline as well. So keep moving by any way possible. And so how we do that is doing an individualized assessment, right? So when you meet with your therapist, we'll, ask what's important to you. What daily activities are really meaningful for you to be independent, to maintain your ability to do. We also have a lot of standardized tests, so we can really identify where you are on the continuum. And these standardized tests also can help assess fall risk. So compared to others of your age and demographic, how likely are you to fall? Or they can do research where you're comparing fallers to non-fallers, and that helps us identify risk. Towards this, we can prescribe individual exercise. I keep reminding my students, it doesn't have to be complicated. And it's actually probably worse if it is, because then if it's too complicated, then it's too much to do, right? You gotta figure out how to get dressed and get out of bed if you have to have this long list of 20 exercises. Most people aren't into that. Some are, and they have an Excel file and calculate how many reps, but that's the odd population. But for most, we're trying to keep it simple. As referenced before, if we'll assess whether it's time, we can work together and figure out if it's time to use an assistive device. You can take them for a test drive, see which one works best for you at this time. And the big one that I wish I had come upon the term or used the term habit way earlier in my career, right? Because there's exercises. We teach sit to stand a lot. It's like one of my favorite exercises is just sit to stand. But the thing that makes me crazy is that people can demonstrate a really nice sit to stand, and then we'll schedule their next visit, and then they'll go, okay, time to go, and do the exact disorganized sit to stand that they did before the training. And so it's like the exercise is also the habit. So every single time you stand, try to stand this new way because it's safer, it's better, and helps your caregiver, spouse, loved one actually not hold their breath so much or get upset because you actually landed softly in the chair instead of crashing onto the chair. No, you're not the only one that does it. Okay, so how can physical therapy help with MSA? Okay, now I never know when my pictures are going to dissolve in or not. So for everyone needs cardio. And yes, it's getting repeated in several presentations. That's how important it is, right? Everyone needs cardiovascular exercise. I would also add sarcopenia happens. Sarcopenia is the loss of muscle as we age. It's just a biologic truth. So we have to fight to keep our muscle mass. So that's really important, is keeping that strength. Also, specificity. So practice what you need to do. If getting out of a chair is hard, then you practice getting out of a chair. Also, easy is not helpful, right? If it's easy, you know how to do it. It's not going to help you get better. Easy does not help you get better. right? So you have to have struggle, satisfaction, and safety, right? So what I mean by that, aside from affinity for alliteration, is it has to be hard, but not so hard that you're not successful. That's when you need satisfaction, right? So about like 80% success rate. So you can make minor, low consequence, that's what I mean by safety. Make mistakes, but not big ones. If you plop back in the chair a little bit, that's okay. If you plop back in the chair so hard that it breaks, that's too much. So small, low consequence errors are where you want to be, and about only 20% of the time, 80% success rate. Okay. So in specific, and I know you're going to get a talk about autonomic dysfunction later this afternoon, so hopefully we'll get some, again, repetition for recall. Recall helps things stick, but people often ask me about what can physical therapy do about orthostatic hypotension. I ask PubMed, scientific literature, what are the non-pharmacologic options for orthostatic hypertension? Not a whole lot, I'm sorry to say. So there are like clothing and sort of garments one can wear that can be probably addressed this afternoon. But there are two things that I would like to mention that also bear repeating. One is the habit, right? That word habit again. And you probably know this already, but pausing in between transitions. Orthostatic hypotension is this drop with a change in position, then you wait and wait to make sure your blood pressure catches up before then standing. And so then when you stand, you don't dash to the bathroom unless you need to, but that's also planning ahead, but waiting for your head to clear. Nice in an ideal world, but sometimes you gotta go. Other things that I have tried, again, no randomized controlled trial data here, but just clinical experience. It's been resistant, but sometimes it works. I'm trying to find the best exercise. But in theory, if blood pressure is a drop where the blood rushes to your feet without the muscle pump to push the blood back up to your brain, then intentionally clenching any muscle to get it back up to your head could theoretically help. So clenching everything from the bottom up, right? Clenching your toes, clenching your thighs, clenching your buttocks, all those things to literally, not like isometric and hold, then that's not helpful, but literally just making the pump yourself by pushing the blood to your head. Raising your arms over your head and pushing, like literally raising the roof on your blood pressure can hope potentially bring your blood pressure up. So preventative wise, exercise also may help the system, because if you have more muscle mass to actually push the blood back up to your head. I also looked this up online and found one paper that had a case study of someone with just neurogenic orthostatic hypotension and not a movement disorder. And they had images of his poses that he was using to prevent the blood pressure drop. I did not put these pictures up here deliberately because none of them are good for anyone with a balance problem. They had him standing really quickly, no pictures. They had him standing like this, crossing his legs and kind of like clenching his thighs together. Terrible. This, like the, basically, what is it, the pirate? Yeah, or like, yeah, but then you have to stand back up again. So the whole idea was clenching those leg muscles, right? Putting a pillow between your knees and clenching that, which brings me to some other topics. Okay, so some particulars regarding MSAP. So the Parkinsonism, there's a lot more research on Parkinsonism and exercise. Some of them for the specific problems, such as the slowness. Rhythmic auditory cueing has been around an extremely long time. Like Oliver Sacks identified it as well in musicophilia, but any kind of rhythm can help get those steps going. This also helps with initiation. But yeah, so for example, marching with music. My favorite is it's May the 4th. May the 4th be with you. Conveniently, remember the music with Darth Vader? ba, 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 ba. Yeah, works great. So any kind of music really helps. And I was trying to find license-free pictures. So these were generated by an AI. I said like older adult using an agility ladder. It could not figure out the agility ladder, those are the things they use in sports. But so and you could use comic book style. But so I put in here, since he's running, he's thinking of the B-52 song, Rock Lobster. Remember that one? Dun, 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 dun. So he's moving his feet fast. Right, for you, you're thinking about 80 to 100 beats a minute. Right, so that's staying alive. This one? Wow, stuff grab. Okay, so 80 to 100 beats a minute is usually a great walking tempo. There's actually clickers on the U-Step walker for that reason. So yeah, and even there's metronome apps that you can use as well to dial in, but anything there. Okay, for the rigidity, stretching can't make it go away, but it can manage. Right, so with a lot of these things, we're not going to make it go away, but you still have tissue, you still have muscle, you still have connective tissue that needs mobility. So your skeleton, you can try to preserve your skeleton while your brain is fighting against it. And so that's why I say stretching is sustenance. Again, more alliteration. And Pitbull doing a down dog, right? Dogs do it all the time. It's just part of their daily routine. So in bed before you get out, just do whatever time of day works for you. Okay. Now, what about MSA-C? So ataxias are difficult because it's the learner, it's the balance center. And so when the learner and the balance center isn't working, generally rehabilitation outcomes aren't as good. And oftentimes, if you see a textbook balance exercise online, it's like stand with your feet in tandem, like when you go to the neurologist and have to do this one. That's just mean. Stand on one leg. So many people come in and say, I can't stand on one leg. I'm like, when do you need to do that? You're not a flamingo. When do you need to walk in tandem? So that's why I have focus on function, not frustration. Yet another AI. So lovely, but yeah, again, fun, not function. So too difficult, sit to stand, extremely functional. My husband made this drawing with Houdini, which is another one of those app things. The other thing I would add with ataxia is that, or any kind of movement disorder, when there's too much energy going into it, again, clinical experience, not randomized controlled trials, but when people are trying to reach something, if you put more energy in, it tends to just like add gas to a fire. But if you ask it to float, less effort, not more, it might just be a little bit easier. So again, this also requires planning, sitting to standing. Putting a lot of energy in the wrong direction can really throw you off balance. But going slow, taking your time for that weight shift forward, then standing up, slow and smooth. Getting that speed is a challenging balance, I recognize. Okay, so for prevention and maintenance, so exercise, when, how to overcome these barriers to activity and find what things work for you. Here are some examples. So a slow, easy stroll for someone who can walk without a device, not necessarily going to be cardio if they're already fit. It's not resistance training, but it is specific to walking. You still are working on your balance, especially if you're going really slow. That's even harder for your balance. And you're getting that social connection in nature. In contrast, a slow walk for someone who just got out of a hospital and can walk around across their house with a walker, well, that might be cardio because they're already working at their capacity. Not resistance training, but it's very specific, and just being upright now is a balance exercise. And they may need more caregiver support and equipment at home. At the gym, your seated weight training exercises. This is probably not cardio unless you go from one to the other, but it's definitely resistance training. And it's safe because you're sitting down. Functional practice, like sit to stands, lunges, getting up from the floor, if it's safe to do so. That's another thing to ask your PT about. Could be cardio. Again, if you do them back to back, one after the other, it's definitely balance. Could be gravity related resistance training, and it's definitely task specific. And then something like Tai Chi. Not cardio, not really resistance unless you don't have a whole lot of strength, but it is very specific for balance, very specific, task specific for standing. It does work on coordination, for learning, social connection, and again, that floating and not forcing. Not particularly great for self-defense unless someone's attacking you very slowly. But it can also be a really great thing for postural awareness and weight shifting. You see boxing a lot in the Parkinson's literature because of Rocksteady Boxing and their great PR campaign. It can be cardio, not necessarily resistance. It's very specific. It's working on speed. It's working on balance, coordination, learning, that social connection, and external focus. And so I asked us that before in regards to Parkinson's, focusing outside your body on the outcome of the movement. So hitting a target, kicking over, like kicking, stepping on tape, stepping on targets, stepping over that agility ladder. Instead of pick up your feet, hit this pillow or kick this ball. You can get a lot more movement out of thinking outside your body than flex my elbow, more like reach here. So keep that in mind because it can be a really great tool. Dancing, my favorite, can be cardio. Not necessarily resistance, but specific, and it's balance training, especially when you're moving in multiple directions. That's a lot of different balance challenge. Works on speed, coordination, learning, social connection, and that music and rhythm again. And especially if you like music, there's a lot of joy involved. So big take-home messages, start where you are. Just start somewhere, move more, sit less. So before getting out of bed, move and stretch a little bit. Stand up and sit down 10 times between your Netflix episodes. Take a loop or two around your home after getting up to use the bathroom. Stand tall and clench your legs 1 time every second while you're waiting for the microwave. Play tug of war with the dog while sitting, of course. Play a beanbag toss with the grandkids or not. You know what? My mother was 94 and I was trying to get her to stand more, and we made some bean bags, and she would literally throw bean bags at like the big gallon water bottles for a half hour. It's great. Of course, she grew up on a farm and she would throw like clods at the cows to get them to go to the right place. So this was something in her wheelhouse. Okay, other advanced things. They're group classes. So they're Sit and Be Fit on YouTube. Bork.org has a lot of online classes for different levels and different abilities. Senior centers have group classes. There are Parkinson's specific programs, and even step trackers and heart rate monitors can be really, really helpful. Oh my gosh, I didn't realize all that. The health app on the iPhone. The big important thing, I didn't even get to that. Okay, dental model. Make a plan with your PT. Your PT can't last forever. So make sure, like when you're done, plan on going in 6 months, every 3 months, just like you go see the dental hygienist, right? You plan on follow-up, because we have so many patients and so many people waiting to get to PT. We can't take you through your exercises 3 times a week forever. Having the plan to do that on your own, so that when you go to PT, there's a problem to solve, so that we can help you do these things on your own, but plan to come check in 3 months, 6 months, so we can measure you again, make sure you haven't declined, and see if there's anything we need to fix. So having that long-term relationship with your therapist is something we're really trying to push for all our folks with degenerative problems, so that we can not lose track of you, and also get you going before the fall happens. Get working on some different or specific exercises ahead of time. So if you don't know PT in your area, look at choosept.com and look for a neurologic clinical specialist. Medicare does pay for maintenance, but it's not enough dosing to maintain. We have to evaluate and see how you are, but we can't, again, you cannot get enough dosing just by coming into clinic. You have to do it on your own. All right, that was probably more than a minute. Thank you. Had to speed up. I blame trying to articulate.
You did a great job. Thank you, Erica. Okay, so a few questions for you. Are there any tips for preparing to stand and avoid dizziness that happens in MSA?
Yes, excellent question. Excellent question. Yeah, so pre-moving, right? So that's a great idea. And you can all actually do this with me. So if you want to come like off the back of your seat, and if you're going to stand up, just doing some like toe taps and ankle pumps. Where's the online camera? So if the folks online will be able to see me, or if I sit down. Over. Okay. Okay. All right. Well, here, I'll just kind of go against the wall if you can see this. So come on. Toe taps. You know, tap, tap. Really like make some noise with it. Yeah. I can't even do this thing down. And then march. 4 times. Tap, 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 tap. March, 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 march. Tap. And look, we got a rhythm going. One more time. Tap, 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 tap. Add one more thing. It's victory arms. Clap. Victory arms. Clap. 2 more. Victory arms. Clap. One more time. All together. Tap, 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 tap. March, 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 march. Victory. 2 more. Last one. Okay, now stand. Oh yeah, I forgot to lean forward and up. So I was working on that forward lean as well, because everybody's afraid of falling forward and they actually fall back in their chair. Forward lean. Okay, next question.
Okay. As somebody says, does that actually help?
Yes. Yes, it does. For some people.
Treatment of PISA syndrome.
Sorry. That's a tough one. Haven't found the cure-all for that. So using mirrors, using sensory cues, tried weighted vests, putting like a what is it? Oh, sorry. PISA syndrome. Idea. Remember the Tower of Pisa? What does the Tower of Pisa look like? Okay, so this is what the brain thinks is normal, or like compels the person, you must stand like this. So like, but yeah, the brain just kind of went, here's vertical. So trying to train that, we're also trying to brain, no, vertical is here. No, vertical is here. So giving weights, we can, and again, no randomized controlled trial data, it's just basically going by what inputs we have. So not a lot, but trying to get that tissue mobility, working and sitting, so that you can actually see, can we get there? Can we get in the opposite direction? There's our entry point. Can you get there? Then push out from there. Get in that opposite position. This is true for dystonia, right? Because if you're here, where can you get there? You need to go lie down and do it. Find that position there, then see if you can hold there, hold there, hold there, then gradually bring gravity back. But yeah, that's a tough one.
Okay, what is the current thinking regarding use it or lose it in terms of muscles? And the person says, he feels like he runs, I don't know if it's a he, but I'll say it's a he. He feels like he runs a marathon every day. He's so exhausted and so fatigued. What's the current thinking about use it or lose it?
Yes. Okay, so use it or lose it is true, but also don't overuse it and prioritize. So like if you feel there's with a lot of these things, like, and it's high energy cost, right? So if you feel like you're spending all your time exercising, what's the quality of life there? So try to prioritize, like, okay, what's how can I budget my time into the most benefit for the least amount of time? Or if I'm enjoying myself, I'm going hiking and it's fun, then do that. But definitely like atrophy. So at the most basic, use it or lose it means atrophy happens. Deconditioning happens. You know, if you've ever had a cold, remember colds before we were masking? Like you're laying in bed a week and then you're like, oh man, it's just hard to walk. I'm over the cold, but man, I'm tired. That's use it or lose it. You lost it. You break a leg and now you put a cast on. That muscle is sad. This leg lost 8 pounds after my ACL surgery because it just, atrophy happens. That's use it or lose it at its most basic. So fitness, cardiovascular integrity, you've got to work to keep that. But if you're spending all your energy just doing those things, then maybe plan your day more around, well, friends and connections are also use it or lose it. So maybe find time to exercise with your friends so that way you can get a twofer. Okay.
Okay, last question. Somebody asks about with MSA, orthostatic hypotension, very common, and this person also has a high heart rate.
Uh,
So, what can they do safely to exercise?
well, usually the heart rate is actually trying to compensate for the loss of blood pressure. Yeah, so that's if your heart rate speeds up when your blood pressure drops, it's trying to do that. So typically, if the heart rate's at baseline without the orthostatic hypotension, that might be a problem. But yeah, that would be something to discuss with your physicians. But if you're worried about exercising safely, probably the safest option for cardio is doing like the recumbent stepper or the recumbent bike. That's for everyone. If they're worried about falling, like the new step is my favorite. They do not pay me. But any kind of recumbent thing where you can work, just get your cardio while sitting down is a really good way of doing that.
Thank you very much, Erica.
Thank you.